presentation by the Dr. Hannah. I should say that Dr. Hannah is my best friend, and I could do my fellowship just because of her, because everything was translated from the Hebrew to English to me by her, and every chance was given by her to me. And she's an excellent orator and able to perform the procedures very, very well. And I can say that she's the first fellow who got the maximum chances to do it. And past more than 15 years, she's doing the TAVI. The TAVI is started in the 2002 by Dr. Ellen Krivier by the first in man implantation. Almost from the 2003 onwards, they started doing it. I introduce Hannah and talk about the case. Dr. Hannah, please.
Hi, thank you. Thank you for the introduction. And Jyotsna she's my best friend. I miss her a lot. Would like to see her. For me, I felt that she's my mentor during her stay in Israel.
No, I don't think it is opposite. Okay, anyway.
And I learned from her a lot, and I would thank what I would like to share with you is my experience with TAVI procedure. We began the experience at 2008, and I hope you can see my screen.
Yeah,
you can see my screen?
Yes, we are able to. Yes.
Okay. Okay, so here you see a photo of my new nephew with his steps. So I think the procedure step by step, and I will walk you through my experience during this year. So every Monday we have a meeting, a heart team meeting, which we have in this meeting interventional cardiologist, cardiac CT expert, cardiac surgeon, echocardiography expert, and TAVI coordinator. We have an ambulatory patient, a special clinic for TAVI, that we see the patient, evaluate them, send him for do the images of cardiac CT and echo, and then we discuss every case. So pre-procedure, we evaluate the patient, the indication for the procedure, the valve imaging, and the access that we'll choose forward. So echocardiography is important, and I think that everybody is know perfect about the echocardiography, but imaging, 3D imaging modalities such as CT or 3D echo is a preferred and route before TAVI. And what we would like to see in this imaging is the annulus. It's a virtual annulus. And we would like to see the number of the valve cast, the extent of and distribution of the calcification, the sinus dimension, the height of the coronary ostia, basal septal hypertrophy, the presence of and severity of mitral valve, if there is aortic regurgitation, and the LV function. This is a patient of 80 years old with critical aortic stenosis with the gradient of 106/72 with mild to moderate AI. And in the heart team, she was high risk for surgery, and we decided to do TAVI on this patient. So in TE, what we see pre-procedure is the severity of aortic stenosis, if there is regurgitation, LV function, other valve disease, as I say, pulmonary hypertension, and the measurement. CT scan, the cardiac CT, we have a lot of information, and I have to say that in the last year, we moved more to CT information about the annulus, the sizing of the annulus. Here is what we would like to see, the annulus, the height of the coronary ostia, the sinus of valsalva, diameter, the LVOT, and this is how we have all the information of a 74 years old male with diabetes, CVA, post-cardiac bypass with severe aortic stenosis. And what is important in this information is the short and long axis of the annulus, the area, perimeter, and the effective diameter. This will let us choose the right sizing of the valve. What we would like to know also is the distance of the coronary ostia. Less than 10 millimeter, it's a risk for coronary occlusion. So during the year, we have a temporal trend that we saw how we change for few things. We can see the, first of all, the TE guidance. In the beginning, we did more TE. Today, we are doing more CT. Considering the anesthesia of the patient, in the beginning, we did more general anesthesia. And today, we're doing more conscious sedation, more transfemoral approach. And this is reflect also the outcome of the patient and the, just a second, sorry. The outcome of the patient, there is less aortic regurgitation, and this is because a new valve that we have in the market. In the beginning, we did more coronary angiography for every patient before TAVI, but with the CT angio, we do more, we do less coronary angio. I think it's important because it's a very old patient usually, and we gave them contrast. Sometimes they enter to pulmonary edema. So just if we see on the CT a very proximal disease, so we will catheterize the patient, and the decision if to make it before or during, just before the valve implantation, we'll have to discuss on it also. You hear me?
Yeah, we are able to hear
Yes.
you very clearly. Uh, Hannah, just I wanted to ask our specialist, Dr. Mona Bhatia, on the CT scan, what else can be the seen, and is there any advancements or anything else is required, if you permit it?
Thank you, Dr. Jyotsna. Yeah, so when we evaluate the CT, what's really important now is to evaluate the aortic root, because you need to have the best fit device. And for that, you need to have good, very accurate sizing. And when we are sizing for the, can you all hear me? Yeah?
Yeah, we are able to.
Yeah. So when we're looking
Able to hear me?
When we're looking at the aortic
Yeah,
root.
yeah, Hannah, you are clear. We are able to hear you also.
So when we're evaluating the aortic root,
Okay, thank you.
we're looking at the aortic annulus. We're then evaluating the size of the annulus, which then gives us the size of the valve that we want to use. So we evaluated both in area, perimeter, and in terms of its diameter. And then depending on whether it's going to be a balloon expandable valve or it's going to be a core valve, which is going to be a self-expanding valve, we decide whether we want to do it by area or by perimeter. Then we look at the valve itself in terms of, is it tricuspid, bicuspid, functional bicuspid, type 0 bicuspid, because the Seaver classification is excellent in telling us exactly what is the nature of the valve. And from there, we then also want to look at the height of the coronary ostia, because when the leaflets go up, we don't want it to occlude or jail the coronary ostia. So typically, you would like a 1 centimeter distance from the base of the annulus to the coronary ostia, but you also want to look at the length of the leaflet. So that is an important feature. The LVOT is the other thing which is important at the level of the aortic root, because at the LVOT, if there's calcification, then chances of rupture and other complications are there. And you also want to look at the sinotubular junction. So that is at the level of the aortic root. And the last is you want to look at the complete access. You don't want excessive calcification, undue tortuosity, atheromas, which may actually have, ulcerated plaques, which may cause rupture of the vessels and the diameter of the vessels, because you need at least a certain minimum diameter for the valve to go through. So you would then look at femoral access, and in the event of the femoral access not being good enough, you may actually consider a subclavian or a carotid or an alternative access. So what's important for CT now is to evaluate the size of the valve, check the correct fit and the correct sizing, because if it's a bicuspid, what is the person, how, whether you want to have the core valve, you want to have the Medtronic valve, and then, accordingly check which valve you're going to be using. There's also the My Valve in India, which is available now, and you want to see which is the best sizing and access route. Hannah, you can. Dr. Jyotsna, any other questions?
Dr. Hannah, do you go for conscious sedation or how is it?
Dr. Hannah, can you hear us?
At our institution, they would do sedation. They would not be doing GA unless and until there are certain other features which require the patient to be under GA.
I think now the trend is moving from GA to conscious sedation.
Yes.
Slowly they are moving on to this.
Hannah, are we audible to you? Rahul, you can contact her.
Yes, ma'am.
Is she in online?
We are not able to see her actually.
She has been disconnected due to connectivity issues, it seems, ma'am.
Oh. Yeah.
She has joined again, ma'am.
That's good. Yeah. Meanwhile, we can discuss about what are the echo features which are very important in evaluation. Of course, the annulus is a very important, which is underestimated than the original annulus. So CT is better to know about the aortic and annulus. But a few of the important features and the echo also we have to see is the valve area, the gradients, and the LVOT size. Especially if it is a sigmoid septum, the implantation of the walls becomes very difficult, and malpositioning of the wall occurs in that.
So, ma'am, as far as indications for TAVI are concerned,
Don't
what is your?
hear you well.
I think she's joined, Dr. Hannah.
Yeah, Hannah,
Sorry.
please go ahead with your presentation.
Hannah, ma'am, can you hear us?
As Dr. Meera Govindarajan is joined, she can enlighten us on the echo features to be the seen specifically for the TAVI.
In TAVR, I think basically you need to assess the valve morphology, the aortic morphology, to look for any calcium in the annulus or the ascending aorta, that is prior to the procedure. And I think after the procedure, you look at the valve, which is like evaluating a bioprosthetic valve only. Only thing is it has got the strut also with it. And there is a physiological perivalvar leak. Normally, physiological leak in a prosthetic valve will be only a valvar leak. In this case, it is seen just outside the strut, so it's a perivalvar leak. We should not get confused that this is something abnormal. Other than that, the evaluation will be based on the morphology and the gradients and the presence of AR more than trivial or mild would be significant. I think that is the brief approach to evaluating the TAVR by echo. I wish I had some prior notice, then I would have brought some recorded images. Unfortunately, I do not have any images with me to show.
Hannah ma'am, can you share your presentation, ma'am? Thank you, Dr. Meera. Hannah ma'am, can you hear us?
Yeah, I hear you. Something went wrong. I'm sorry. But did you see my presentation till, I don't know.
No, we are seeing your video, but not the presentation.
Ah, okay. I will share my screen again because I was continue to talk, but now you see my presentation?
Yes, yes.
So
Peripheral angiogram is available.
yeah,
Please.
this is a periphery, and I don't know till when but I will continue from here if it's okay.
Yeah, please go ahead.
About how we choose a different valve. So in our hospital, the majority is a volute family, is a self-expandable supraannular valve with the ability to recapture and reposition when the valve is less than 80% deployed. Good durability. The second family is Sapien, is a balloon expandable, very good valve with intraannular valve, low frame height. It's important when the patient, we need access to the coronary for future access, good durability data. The last year we began a program with the Accurate Neo that is a self-expanding supraannular valve. The deployment is a bit different. I will show you a few cases. Low pacemaker rate and flexible delivery system. For this valve, there is a new data that is the non-inferiority according to the Sapien and the Evolute, but I will talk about it later. You hear me? So every valve, we have a sizing chart, and we choose the valve according to the CT and the information that we have. We have to anticipate every complication if it's possible to avoid it. If it's for vascular access, conduction disturbances, especially patient with RBBB or conduction defects, so we'll choose a valve with lower pacemaker rate, coronary occlusion, annular rupture, and stroke. So during the procedure, we decide the anesthesia. In the latest year, we moved to conscious sedation. And we see that I think it's not everywhere we doing more conscious sedation. It's better for the outcome for the patient. What I will show you here, if you hear me, you hear me?
Yeah, we are able to.
Okay. This is a patient. It's important because in the end of the procedure, we want to see the patient awake. We had 1 month ago a patient that in the end of the procedure was, she had dysarthria, and we asked the anesthesiology if for him the patient should be awake or still it's influence of the medication. He said, no, the influence is over. So we rushed the patient for the CT. We saw an occlusion of the mid-cerebral artery, which has aspirated, and the artery was open. And the day after, she's a patient of 87 years old, the day after she was sitting and reading a book. So it was a really good satisfaction. Vascular access, we have transfemoral. This is the majority of the cases, transaxillary, transapical, it was in the beginning. It's really rare if we're doing it these days. Transcaval, I don't know if you have experience, but we are not doing this. And transaortic, we had bad experience, one case a few years ago, and we're not doing it anymore. So when we're going to do the vascular access, there is few things that it's important because what we understand that this is the majority of the valve implantation was the easier part, but the vascular complication was a problem. So there is few possibility to do it with micropuncture, ultrasound guided. What we're doing is contralateral iliac injection and put a safety wire. We have to stick at the anterior wall and above the bifurcation, above the calcification, and then we put the 14 French according to the valve type and heparinize the patient. This is how we do it. First, the injection and the safety wire.
Nowadays, all the valves are compatible with the 14 French?
All the valve, yes. No, sorry, the volute, the large part is 16 French. This is the higher 16 French. But the volute 29, there is a volute plus that they're going to be compatible with 14 French, the newer part. So what we're doing, we put a coronary grand slam wire as a safety wire. So if we have any perforation or any problem, so we put a stent in the common femoral. We prepare before we closure device. Also here we have changed the practice. In the beginning, we use more POSTA, which is suture-based closure device. Then we moved to 2 ProGlide, and now we're using more and more the Manta, which is collagen based, and we have a very good experience with it.
Is that collagen-based closure is also very effective as the suture-based one?
I think it's the same, but the problem is with the suture-based device, we saw maybe more occlusion of the vessel, and but I think it's more or less the same as the ProGlide. The POSTA is more bulky, so I think with the POSTA we had more problem, and especially if it's very calcified, so you see the needle here won't open. With the ProGlide, we had to prepare the skin. We have to tunnel, and sometimes there is bleeding from this tunnel. So what we see lately that the Manta is functioning very, very good. We entered the large bore sheath. Usually it's 14 or 16 is for the biggest valve. And then, sorry?
A question.
Yeah, is it 14 by 16? The sheath that is expandable up to 16?
Okay, so it depends on the valve. This is for the Edwards valve, the balloon expandable is the 14 that is expand. So in the end, it's like 18 French. But the Evolute had the sheath on the delivery system. What I'm doing with the Evolute, I usually put the 14 French. It's also for the company. The 14 is sent Trump called the sheath, just to do the tunnel, and then we enter for the Evolute. The Edward is expandable sheath. I think that the best one is of the Boston Scientific for the accurate. It's called Ice Sleeve. It's the best sheath, I think, that it's very slippery and enter very nicely. The valve implantation, so we put contralateral, we put a pacemaker. We put for every case, unless the patient had already a pacemaker, so we'll pace him externally. I know that there is few that can do the pacemaker on the wire. We are not doing this yet, just to not to stick also the vein. And contralateral, we put also a 7 French sheet like this. We put the pigtail and the aortic injection. From the CT, we have the injection for the annular. This is what we would like to see, the 3 leaflet, the sinusoid, the annulus, for good implantation, good angle. After we put, this is contralateral, and then from the 14 French, we put the, this is how we choose the annular.
Do you do the rotational angio to see that exactly all the 3 cusps of the sinuses are at the same level, or you do go to the LEVO 20 and cranial 20 or a fixed views?
We would like to see all the sinus in the same level. And we have this angle from the CT, from the beginning. Like this, we want to inject and try to find the angle during the procedure, and the patient will get less contrast.
You select the operator's view from the pre-done CT?
Sorry?
Yeah, the CT would normally give you the implantation angle actually.
Yes.
So from the CT, you can already have your implantation angle. That way you will not have to do excessive aortograms and excessive contrast and shoots. So you would already know where cranial caudal LEO, REO, whatever, will give all your 3 cusps in the same line.
Anna, can you highlight a few of the softwares where it is helpful in placing the things, all the 3 cusps at the same level on the cath also?
On the catheterization, what we would like to see is usually we saw the calcification, so it gives us more or less the clue where all the sinus is. But I think it's very individually for every patient. So basically what I see and what I do in angiography is to see the calcium, try to see where is the plan of the calcium, and try to understand the angle of the precise angle for implantation. But this is with the help of the CT.
So in which cusp do you
Sorry?
prefer to keep the pigtail catheter? The pigtail is in which cusp most of the times?
It's a non-coronary cusp. Right. We can see it in the picture here. It's a non-coronary. There is few that talking in the last year about overlap, cusp overlap, that will give a proper height of the valve. I must say that we didn't adopt it yet, but I think it's a good idea to use more than one angle.
Okay.
So after we put the pigtail, we cross the valve with the amplets left one, and then we exchange for pigtail. We put the pigtail and see the gradient. This is the patient that we did last week with the critical aortic stenosis, and then we switch to a pre-shaped wire. This is the procedure. I show you usually we cross all with Butkin right or the amplets left and the straight Terumo. And then we exchange to a J-tip catheter and put one of the pre-shaped wire is the or Safari or Confida. Usually we use the Confida. The Safari is more, I think is more bulky than the Confida, but it depends on the operator, I think. This is how it looks. We have to to take care of this wire because it's stiff wire, and we have to keep attention that it won't be too apical, not to rupture the LV. And then we're going to choose which kind of valve. I will show you a few cases with each valve. One of it is the Evolute. As I already told you, it's self-expandable with the skirt, pericardial skirt that to prevent PVL. And what's important in this kind of valve is the recapturable and repositionable option. And also for if the patient has PVD, so it's 14 French and it's lower profile, so patient that before we would send to transapical approach, we're doing today with this kind of valve. This patient has already a pacemaker, so we could pace the patient externally. This is the valve, it's self-expandable, and we check that the valve is mounted correctly. There is a paddle here that we have to check that are okay. And then the aortic arch into the to the valve. And it's self-expandable, so we begin to deploy the valve. We can deploy it until 80% of the deployment. We can retrieve the valve if the position is not correct. We're aiming for 3 millimeters below the annulus. Annular contact. This is the first opening is very, very slow. Like this, we can control the opening of the valve and the good position, and then deployment of the valve. We have to take care also of the nose cone, because sometimes when we take the nose cone, when we take out all the system, the nose cone we had a case that the nose cone provoke an embolization of the valve. So we have to first centralize the nose cone when we take it out. And this is how it's looking the end of the procedure. The height is very good and with no leak. And this is hemodynamic that we would like to see with no gradient. The other valve is the balloon expandable, which is a low frame height with skirt to prevent PVL, and with the Carpentier-Edwards Thermofix to reduce risk of calcification. It's a bovine pericardial tissue. Here are also the step of the implantation. This valve enter expandable valve, expandable sheath, and what we have to do is to take the balloon and pull back to the valve, and then the deployment is different. Now it's taking over the aortic arch. Pull back the catheter. And here it's very important, the pacing. The pacing will be okay, because if there is any VPBs, it can embolize the valve. Also here, the deployment is not a full open all the valve, but 2 steps to open it, 1 step, and just to see that and fine tune the position.
What was the delivery system? It is a Novaflex or Retroflex?
It's a Novaflex, I think. This is the the result. This is the accurate neo, and this is the sheath that I think it's the best, the eye sleeve. They won't sell it differently. It's just with the valve. We asked them already. And it's interesting is a different type of opening. It's up, top down, with the upper crown and afterwards the stabilizing arch, and then the lower crown. I'll show you how it's also here. This is the lower crown stabilizing arch. We open first the upper crown stabilizing, and in a second time we'll pace and open the lower. I think also here, even though the company in the beginning tell us that we don't need to pace, but I have a case of embolization because of VPBs. So in this part with the opening, I always check for the pacemaker if it's okay, and use with pacemaker. I know that there is a lot of, I think this is, when I use this valve is really a niche valve because it's very hemodynamically stable during the procedure. So if I take patient, I'll take patient with LV dysfunction or patient with the coronary is very, very low. Even 8, we did it less than 10 millimeter. And there was any problem with the coronary valve. What we use, and it's important, but not in every patient, we use it in several patients, usually because we don't get reimbursed and it's very expensive. It's a brain protection device.
Do you routinely pace in case of core valve also?
Core valve, we don't routinely pace, but it depends on if there is a lot of VPBs or it's not stable, so we will pace. But just in the beginning of in the first third part.
Okay.
But with core valve, it's less important for me than the other valve.
Yeah.
So brain protection device, we use it usually if the patient had already a CVA or a very or calcium score that is high. And this is from 2 patients that we did. You see, this is a really big calcium and thrombus that we saw. I don't know if you use. What is your experience? But it's easy to use. What we have to see just is when we pass the valve not to interact with the sentinel, usually there is no problem. This is the manta. We finish the procedure, and this is how we want to see the patient without any leak or perforation. There is few challenges, technical challenges when we implant the valve.
Please can you say what type of the valve you wanted to take it in, what type of the cases?
Okay, usually it's when we use the 2 valve that you use, it's Evolut or Sapien. If the patient had the normal coronary and we don't want to have a future access, so we'll take Evolut. If we have patient that already had PCI or we want a lower risk for conduction abnormality with Sapien. I'll show you here according to different type of challenging cases when we'll use. If we have the generative surgical valve, And if it's really small valve, we'll take the evolute because it has a greater, lower gradient, especially if the diameter is less than 20 millimeter. This is in the generative. If the patient have bicuspid aortic valve, usually increased risk for PVL, higher rate of calcification. And in this anatomy, we will use more sapien. I think that the Lotus Edge, it's a new valve that will give us more in patient that we are afraid, also the bicuspid, but also in patient with higher calcium score that we want, we are afraid from annular rupture, be the valve that it's more suitable. In cases of pure AI, I don't think that we have a valve that is good for that if it's pure AI. Here they're talking about the Jena valve, but I don't have any experience with it. About the coronary obstruction, we have to say, because there is a lot of parameter, if the coronary ostia is low, but the sinuses are very big, so we have space for the coronary and there is no problem. If there is a very small anatomy and the coronary ostia is low, so I think in this case I would take the accurate valve. This is, I think, more and the last in a few years, we saw more and more valve-in-valve procedure of the generated prosthetic valve. It's very important to know the different type of surgical valve. Especially we have the mitral flow valve that it has a externally mounted valve that has higher incidence of coronary occlusion. There is special technique to overcome this, the basilica that cuts the valve, but the valve leaflet, I don't have experience with the basilica. This is a valve-in-valve procedure of mitral valve. We do the transeptal balloon and this is another, we put a steerable catheter, the Agilis, enter a wire, and then we put the valve with the help of 3D echo. And this is how, this is a patient we did in the beginning of this few days ago. For valve-in-valve, we use the sapien. For mitral is the sapien position. We can see it with good result. And this is another patient that has a mitral flow valve with lower height of the coronary, but we aim to put the evolute like this, that the sinuses, the lower part, the lower part of the valve will be near the ostia, like this. It will it had the perfusion for the coronary artery. This is a patient that has a severe aortic regurgitation. So if I summarize, what it's important is the patient evaluation, to have the imaging with all what you talked about, the sedation type, access confirmation. Every case that we're doing after the meeting, before again before the procedure itself, we do a re-meeting and we'll see all the parameters. We have to see the access confirmation, if we use brain protection device, to decide whether to do a pre and post balloon dilatation. Lately, we're doing less pre-dilatation unless it's critical aortic stenosis, and post-dilatation depend on the PVL that we'll see in the end of the procedure. Valve selection confirmation, and to anticipate to avoid complication. So thank you. And if you have question, please.
How do you decide the use of the brain protective devices in each patient, or regularly, or how do you screen them for that?
We're not using it regularly because we don't get reimbursed, and we have to get a permission for every patient that we use it because it's too expensive. So it's not every patient. What we use in patients that they have previous stroke, and the patient with the calcium score that is very high. But it's not that we have any criteria in which one to use.
So you had shown one patient, no, in which the patient had a stroke and which cerebral artery was occluded. What was done for that patient exactly?
Aspiration.
Okay,
only aspiration. After the aspiration, it was
right.
open. But we were lucky because we have in the same floor the radiologist,
Right.
so we just moved the patient from one room to another, and she gets really immediate treatment. The problem is that usually you don't, until you understand that the patient really has a stroke, because after sedation and when he's awake, not awake, so it took a bit of time.
I'm going to add a comment here that, in India, we have a lot of infective endocarditis also. So there's sometimes there are vegetations on the aortic valve, in which case, again, you need to be careful because some of those vegetations just fly off and become embolizations. So there again, you might want to use some protection devices. So we had a patient who had this, had these friable vegetations on the valve. And although protection devices were put into both the neck vessels, but finally, it ended up getting embolized and occluding the iliac. So they can fly anywhere. So you've got to be really careful there.
Dr. Hannah, so when you do a valve-in-valve procedure, what is your anticoagulation regimen post-procedure?
It's one of the biggest questions because there is no exactly unique regimen. We try to do our protocol to give, usually if the patient is already on anticoagulation, so we continue the anticoagulation. But currently we are not prescribed anticoagulation routinely. We giving usually aspirin and Plavix, but it's a big question. I think this is a question. For my feeling is that they should get maybe for 3 months, like after surgery, after valve surgery, and then to see. But from the other hand, we're treating patients that are very, very old. So we're afraid from the other part for the bleeding. What is your experience with that?
Right. We did a valve-in-valve procedure. What we did for the patient was for 3 months, we used anticoagulants. And then after that, we switched the patient to antiplatelets, dual antiplatelets.
Yeah.
Yeah, one more concern is about halts also. That is hyperattenuated.
Yes.
That is seems to be the much more frequent when we don't give a proper anticoagulation. So this is likely to have a more degeneration as subsequently as the event rates. So that is seen when the ineffective anticoagulation.
I have to say that from time to time we see HALT patients. We follow this patient, and if we see really a gradient, a higher gradient, we send them to CT to see the HALT, and then we gave them anticoagulation after a while, and we rechecked it. But it's not that we have really data for our patient which one will do HALT or not. So I don't know to tell you exactly this information.
What was
And
your
Dr. Hannah,
experience with
what's
the
your
transapical route?
Sorry?
Your experience with transapical route?
Transapical?
Yeah.
Transapical, only in the beginning we did it for patients with severe PVD that we didn't have any other access. We didn't have a good experience. In the end, it was like, the outcome was like a surgery. So I think not only for our center, but all over the world, we lowered this procedure. Today, I don't think in the last year that we did the transapical procedure.
So in case there's a peripheral disease, what is your experience of any case where you performed an IVL for a peripheral? Because IVL is one thing which we are about to discuss today. So do you have any experience of having used an IVL in the
I
iliofemoral
have to
tract
say
or
that
down there?
the first time that we used IVL was 2 weeks ago, something like that, or 1 month ago. But I hear that there is a very, very good experience with that. I think it's a good technology, and also for the peripheral, yes.
Yeah, peripheral for
peripheral,
TAVI,
I think it would be okay.
Have you done any cases of the sigmoid septum transfemoral implantation?
I didn't understand.
Sigmoid septum. That is, then LVOT will be the bulge will be there.
Yes.
Yeah.
The problem with this is we concern about embolization of the valve. If we have a bulging septum. Usually we use the Evolute, and like this we have the opportunity to recapture, reposition if we have any problem. But I think with good pacemaker and valve opening technique that is very slow in the beginning, there is no problem.
Usually they say that nanotechnology based second generation TAVI may require only 10 French size of the sheath, because Israel is very well known to have advanced technologies. Are there any studies are going on there?
For 10 French, we all hope, but I don't think we're there yet.
Okay. Any more questions from anyone? Yeah, if not there, I request Hannah to continue with the reveal her case presentation. And as we already know that IVL came as an alternative to the rotablation, but I don't say that each and every case we can use an IVL. But as it is simplified so much that the rotablation really requires one person to do the rotablation effectively. But of course, IVL is almost like a simple annuloplasty doing procedure like. Major thing it is actually after the inflating the integrated balloon to 4 atmospheres, small sparks at the emits and vaporizes the saline contour solution and creates a bubble which rapidly expands and collapses within the balloon. This expanding and collapsing the balloon creates the short bursts of sonic pressures, and this can effectively can produce up to 50 atmospheres and has a localized effect on the calcium and can give away the both intimal and medial calcium. So I think it is a very good technology, and we will hear from the Hannah a case of a instant stenosis. Please, Hannah.
Okay, we'll share my screen. Okay, so I think that you're aware of the technology, and I just will show you the case. It's a 77 years old patient. You see my screen?
Yeah, we are able to.
Okay. So he was a 77 years old male with type 2 MI, post pneumonia, with atrial fibrillation treated with NOACs. And he came to the cath lab. This is his right coronary artery with total occlusion. And this is what we saw, lesion in the mid LAD. And the operator that did the procedure had the impression that the balloon is open, and he was implanting a stent. You can able to see that the stent is under expanded due to calcium, and he tried every balloon that can be possible in the cath lab, even the post high pressure balloon, and the lesion remained the same. And we didn't have this technology. So what I did, we hospitalized the patient, and we had to ask like a compassionate use for this. And 2 days after was under control, we bring the shockwave procedure, and after a few balloon implantation, a few balloon shock, we can see it here. We had a very good result. I think it was after 4 or 5 courses of the lithotripsy. And this is the final result. We're very happy. I know that it's not, it's off-label use in stent restenosis, because usually it's for calcified, very calcified lesion, but for a native artery, and only for a lesion that you can pass a balloon, because if you cannot pass a balloon, so autoablation is the better procedure. There is few trial, also the Disrupt-3 that was lately published in the TCT with the safety and efficacy, and also for peripheral. But this is the experience that I have. I think that I can learn from you more about the cases or complex cases that you use. Thank you.
Is the imaging was done in this case?
No.
Means attempted and not passed, or not planned to do it?
No, there was planning to do the OCT, but in the end, they in the first case they didn't, and we put we did directly the shockwave.
Okay. What was the initial balloon used to dilate before stent implantation?
It was a regular balloon. You want it's a compliant balloon, semi-compliant.
And what was the size of the lithotripsy balloon selected?
It was 3.5 for atmosphere.
So 1:1 ratio, no? To artery to
1:1 ratio.
It's 1:1, yes.
So imaging is not a must, is it, for performance of IVL? It would definitely be of help, but in case some center is not equipped with an imaging procedure, still an IVL can be done.
Yes, it can be done. What I would like to know, Dr. Hannah, did you try using an OPNNC balloon?
Yes, it was also higher. This is what it was a high pressure balloon with 35 atmosphere, but it didn't open. This is one of the problem, I think, that not always we could predict the calcium in the artery. So this is one of the problem. We should prepare the lesion properly, but not always we can do it. I don't know if you have in your cath lab the possibility to do shockwave whenever, because for us it's the technology will be on the shelf, but it's not something that I have ready now.
So what do you think that when we are breaking the circumferential calcium around by inflating this lithotripsy balloon, do we harm these stent struts also? Because this is now happening in stent.
Sorry, I didn't understand.
Now that we are inflating this balloon, which is going to act on the calcium, the effect of this shock waves that happens axially, would it be affecting the stent struts as well? The fractures are going to be inflated.
What I heard from the company is that it affects the polymer. So maybe it will be a bare metal stent in the end, and not a drug-eluting balloon, a drug-eluting stent. Sorry.
Right.
So I don't know if maybe to do DB in the end of the procedure will be correct, but I don't know to tell you. I don't think there is any data.
So actually, what happens is that if see, in this case, it was an instant restenosis. So this is an old stent which was there. When you do it in an instant restenosis, it is considered to be relatively safe. The problem is when you do it in a freshly implanted stent. So if you've implanted a stent and the stent still hasn't dilated, you had expected it to dilate. You've used a shockwave lithotripsy already. You've implanted the stent and it still hasn't completely dilated. That is when they say that if you're going to use shockwave again inside this freshly implanted stent, there are chances that you will break the polymer and there is a risk. Now, having said that, I have run into a case like this and I have actually used IVL again in a freshly implanted stent. Luckily for us, nothing happened, but it's an off-label indication. The companies, people say that if nothing works, you can try it.
Yes.
Actually, it is almost like a stent ablation. Like when a rotablation has come, in the beginning they said in the native calcium only it has to be done. Subsequently, the stent ablation with the previously implanted stent was done. And lastly, they used even in the freshly implanted the stent also. Our main aim is to have the luminal gain. But all these stent struts, which are the microparticles goes and obstruct the coronary bed, is always is a risk.
There's always a risk. Very true. And the indication expands as we work.
Yeah.
Do you have any? I have two patients with non-dilatable, previously non-dilatable stent in vein graft. So I have intention to use this technology. I don't know what. I think it's better that the stent will be open than under dilated because the patient is returning with instant restenosis.
It can be used.
Do you have any experience with
it
vein
can
graft?
be used. In vein graft also, we can use it. Incompletely unopposed stent, yes, we can use it.
Okay.
The risk of perforations is said to be low, otherwise also in native coronary, because low atmospheric pressures, I think around 4 and then max up to 6 optimal is being utilized.
Yes, but what we normally do
Probably
now is
should in the venous grafts. Yeah.
IVL is new in the shelf, so all these indications in instant stenosis or SVG grafts and all will not come now because it is still in the initial stages. But I think with the experience, all these indications will come because we have no other option left.
Yeah. Thank you, Hannah. Thank you very much. Now we are going to hear from the Dr. Sarita Rao. She is an experienced cardiologist, and whatever you say that, are you doing this procedure? She's saying, yes, I'm doing it. So I'm happy to hear. Previously, we heard about the denervation, renal denervation for the antihypertensive treatment. So now let us hear to Sarita Rao about her interesting cases of IVL.
Thank you.
Thank you, madam.
Dr. Hannah, if you can unshare the screen, ma'am.
Yes.
Yes, Dr. Hannah will have to unshare, then only I can share.
Just a second.
But Hannah, stay back.
Yeah, I'm with you.
Thank you.
Sita ma'am, can you share screen now, ma'am?
Yes. Well done.
Yours is shown as a half. I think probably you have to go to presentation mode. Yeah.
Is it visible
Now
now?
good. Yes, yes. Excellent. Good.
Thank you, Dr. Jyotsna, madam, and a special welcome to Dr. Hannah for joining us today. And good evening, ladies and gentlemen. I will be talking about making complex simpler with IVL, interesting cases. Now, I'll just elaborate about the scheme of this presentation. The scheme of this presentation is, first of all, cases where we failed. Where we had ROTA, we didn't have IVL. Cases where we failed because we had OPNNC, we had ROTA, we didn't have IVL. And then cases where we succeeded because we had IVL. And then cases in which we used IVL, but with not such good results. So basically, what I want to emphasize is that when you are approaching a calcified lesion, you need all of them. You need rotablation, you need OPNNC, you need cutting balloons, and you need IVL. So all of this should be available when we are dealing with such cases. So now fibrocalcific plaques, they reduce the vessel distensibility and they impair a full uniform balloon dilatation and subsequent stent expansion. Various technologies have been developed in order to tackle this problem. Rotational atherectomy, which has till now been considered an adequate choice for plaque preparation when dealing with highly calcific lesions or even after balloon failure. However, when you have larger vessels and in lesions that are not so tight, our rotablation burrs might not be able to ablate the plaque. And if at all, it only modifies the intimal calcifications and it doesn't deal with the circumferential calcification. So today in this presentation, I would try to elucidate the reason and the ease with which these calcified plaques can be dealt with by the use of IVL, thus making the complex simpler. So the challenges of treating calcified coronaries have been well elucidated in these major trials where they had almost 7,000 patients enrolled. And when you looked at the event of death, MI, target lesion, revascularization, and the major adverse cardiac events, all of them, the outcomes were worse after intervention with the calcified vessels. So my first case, 37-year-old gentleman, young, chronic stable angina, class 3, family history of premature coronary artery disease. Echocardiogram was normal. His coronary angiogram received a circumflex 90% stenosis and an RCA 80% calcific stenosis. Now this was the right coronary. So the LCX angioplasty had been done without any issues. And when the RCA was attempted, the wire crossed very easily. A 2 into 15 millimeter balloon crossed, but it was not able to dilate the lesion. Subsequently, we went ahead to cutting balloon, that also failed. Subsequently, we took in rota. I took a 1.5 bar of rota, 2 to 3 passes of rota was done. Again, a 2.515 balloon is crossed. Again, it is not able to dilate the lesion. A 3 into 14 OPNNC balloon is now taken, inflated to 40 atmospheres of pressure, but the lesion again will not yield. So what? This procedure was abandoned as we did not have IVL at that time at our disposal. Second case, 70-year-old gentleman, acute inferior wall MI, post-angioplasty 2012 to the RCA. He had a restenosis, 100% occlusion, attempted at Mumbai. Balloon could not cross, but flow was established over there. Patient was discharged. He came to us after 1 month, again with an acute inferior wall myocardial infarction. Post-procedure RCA, again 100% occluded. This was the angiogram. Again, his RCA has shut down. Lesion was dilated with a 2.512 NC balloon. The lesion did not dilate. However, a flow was achieved. So symptomatically, he became a little better. A 3-12 non-compliant balloon could not open the lesion. It ruptured. Subsequently, I took in rota, a 1.5 burr, 3 to 4 passes done. Post-rota, we deployed a 3.515 drug-eluting stent. After that, it was again dilated with an OPNNC at 38 atmospheres, and this was the final result. The nodular calcium could not be tackled. So now we knew that we needed something more than rota ablation and OPNNC. Patient is on a follow-up of 4 years, still doing well. Check angiogram still reveals not such a good result, still some stenosis there, but he's doing well. Now, third case. One more reason where rota would not be as safe, and IVL makes the complex simplified. This is companion embolization during rota, the Fokerton masked menace. 51-year-old gentleman, diabetic, hypertensive, angioplasty to RCA 4 years ago. Symptoms recur, echo shows EF of 30%, angiogram reveals a circumflex osteoproximal 90% long segment disease. EDAD calcified, 80% stenosis, RCA is a CTO, instant restenosis. All of these, he was advised a bypass surgery, which he categorically denied. Now this patient comes, RCA, there's instant restenosis, it's a CTO. Circumflex, you can see, long lesion, 90% osteoproximal. LAD, calcific, 80% stenosis. The problem with this patient was he had a bad circumflex disease. And he doesn't want a bypass. So the LAD, we did a rota ablation. Post-rota ablation, we went ahead and stented the LAD. Good bed prepared after the ablation, stent implanted. A good result with the LAD. Went ahead, now LCX was attempted. Now I was doing this as a live case. Incidentally, patient's son is final year MBBS student. He was also watching the procedure live. LCX was attempted with rota. Now what happened? We took a 1.25 burr for the LCX. The LAD was a 1.5 burr. Post-rota, there's no flow in circumflex and haziness of the LAD ostium. And immediately after that, there is no flow in circumflex and LAD, followed by a cardiac arrest. Revived by daughtering in the LAD, low pressure dilatation, also liberal use of nitroprusside, Nicorette, shifted out, tyrofibin on board, temporary pacemaker inserted, patient on ventilator after establishing good flow. Revived, shifted out, tyrofibin on board, TPI ventilator, flow achieved. Now, what happened? The reason for this phenomena was that slow flow, no reflow results from microvascular embolization of atherosclerotic debris thrombi, platelet activation, and vasoactive mediators, and is associated with peri-procedural MI. It has been hypothesized that the microcavitation created by the rotating rota ablation burr across the lesion also contribute to the slow flow and no reflow. This transient microcavitation phenomena directly correlates with the rota ablation speed, the burr size, and the duration. The incidence of this complication has been reported to be about 2.5 to 5% in reports. Technical factors could contribute to this, including the use of larger burrs, longer runs, sudden deceleration. Optimal technique, use of continuous flush solution, antithrombotic therapy are preventive strategies. As soon as the burr was removed, there was embolization in the LAD from the shoulder of the burr, which caused slow flow in both the vessels, leading to this catastrophe. Managed it with distal bed perfusion with vasodilator, tyrofibin given through a microcatheter, which is the cornerstone of treatment here. Next day, we took this patient for an angioplasty to the circumflex, the RCA CTO, which was uneventful. Patient was extubated the same day, stent delivered, deployed smoothly. Post-dilatation done, final result. RCA instant CTO dealt in the same way, ballooning, post-stenting, stent deployed with it, further issues. Now, in our case, LAD was the side branch as it was an ostial circumflex. Since the secondary protective wire could not be used with the rota ablation system, so careful attention should be given. Most of the cases due to microparticle debris or vasospasm, in contrast to the usual angioplasty in which it is due to plaque shift. To prevent occlusion, the burr can be platform distal to the takeoff of the side branch if possible. But in pullback, there are chances of companion or side branch embolization, leading to the cardiac arrest, aptly exemplified in this case. So it is important to adequately flush the rota before taking out the burr from the vessel. Osteal lesions, try to avoid and if at possible, use smaller size bursts for very short times. Now, these three cases, they suggested that the intramural or the circumferential calcium needs to be tackled in a different way, as rota, cutting balloon, OPNNC failed in these cases. So now we come to the case 4. Now, this was my first case of IVL. We took a simpler case for our first case. Now, with intravascular lithotripsy, the cream comes with the cake. 78-year-old gentleman, eccentric calcified mid-LAD disease, presented with inferior wall MI, underwent a primary angioplasty to the RCA, and then we took him the next day for an interval angioplasty to the LAD. You can see the amount of calcium in the proximal mid-segment. Now, the IVL balloon first pulse, it was like a sound and light show with just a click of the button. You would see the calcified lesion slowly dilating, very soothing, as that's the first time after the tyranny of rota ablation. Recrossing the second time with the IVL balloon was smooth. The second pulse being given. And gradually you can see there is further dilatation as you increase the number of pulses. This is the third low pressure. And this is the fourth final pulse. Now, post 4 pulses of IVL, each pulse of IVL is about 10 pulses is given in each sitting. And so we have given total of 40 pulses. Stent crossed smoothly. And this was the final result. Just a minute. So the intravascular lithotripsy, it is inspired by urological applications, but it is designed for the cardiovascular system. This is how it is. This is the generator and the connector cable to it, which is attached to the balloon. There are 2 emitters that pulse once per second. It has 80 pulses per catheter. You can use it in different lesions also in the same patient. It is an integrated 12 millimeter semi-compliant balloon on which it is. So we normally go up to 4 atmospheres, and then after the pulses are finished, you inflate up to 6 atmospheres. If you're worried it is going to rupture, then you don't go up to 6. We stop at 4. Now, this was a first case of IVL, and we were much relieved to know that we don't have to push rota in many of the calcific lesions. So what did we do? This is a 79-year-old gentleman, diabetic hypertensive, post-PTCA to the RCA. He developed a severe calcific stenosis just after the stent and also a 50% in-stent restenosis. So this is the patient. A 2x10 non-compliant balloon failed to open the lesion. It's not dilating. The lesion did not dilate. So we took a 3x14 IVL balloon. 4 pulses were given just distal to the lesion. Repeat pulses of IVL, mid-RCA. The lesion opened nicely. Subsequently, the stent was passed over a Godzilla as there was proximal calcification as well. Uniform dilatation of the stent. Post IVL, proximal RCA was also stented. And this, just a minute, let me show the final result. This was the final result. So IVL made things very much easier. So we got very aggressive and we started using IVL in a lot of cases. But we realized that the good times don't last long. And here we stumbled into hard rock. Now, after that horrific retrograde flow, we wished we had something simple, and we got IVL on board after the rota embolization case. This is a 67-year-old gentleman, inferior wall myocardial infarction, 45% ejection fraction, recurrent angina lately unstable. Coronary angiogram revealed a triple vessel disease with huge chunk of calcium in all the arteries, categorically denied a bypass surgery. So this was his angiogram, codominant circumflex with 80% eccentric lesion, heavily calcified LAD with mid-distal 80% calcific stenosis. You can see the amount of calcification along the entire length of the LAD. Codominant RCA, CTO. A 2x10 millimeter balloon was negotiated across. Now the balloon was undilated. There was dog boning of the balloon. Distal lesion crossed. But repeatedly the balloon kept slipping and failing to dilate. Now, then we took the IVL. Now with the IVL, we had a partial dilatation and then this balloon ruptured. So now we have a problem at hand. We need a second balloon. It is quite costly because at our center, it costs about 2,85,000 just for the balloon. Thankfully, the company people provided one more free of cost.
This balloon bursted at 4 atmospheres or what happened?
Yes. No, the moment I went up to 6, it burst, which is why, after that we had 2-3 ruptures. After that, we stopped going up to 6. Wherever we thought that the lesion is bad and there are chances that it will rupture, we have stopped going up to 6. Now the IVL balloon, the second IVL balloon, it successfully dilated the lesion. This is the second IVL pulse with the new balloon.
So with a single pulse only dilated?
No. Repeated pulses are required. So basically in this LED, we used 4 of the pulses, which means 40 pulses total. And then we use the rest of it in the next vessel. Post IVL, now we have an adequate bed prepared. So the lesion is again dilated. Now, the stent is not negotiating around the bend, as you can notice, even after the IVL, and that's probably because of the angulation. You can notice the splaying of the wires as we are pushing it. Dilated with a 2.515 NC balloon at the bend after 4 pulses of IVL. Still the stent did not cross. So guideliner was taken to deliver the stent. Mid part of the stent, as you can see, is still indented. This is just to show the amount of calcium in the coronaries. Again, LCX was calcific, again dent with OPNNC post-IVL. Proximal stent was deployed with ease. Post-dilated with OPNNC 15. And this was the final result. Different views for the final result. So when we talk about a basic approach to treat calcium, so basically important thing is the assessment. You can use CT, angiographic or IVES. And when you're talking about heavy calcification, angulation is large, thickness is more than 0.5, increased length greater than 5 millimeter, you would think about calcium modification using the different ways or a combination of the ways, using the NC balloon, the cutting balloons, the IVL, rota shock, combination of the two or one of the either, and of course use of guideliners if required. So my assertions were, too much of calcium is very tough to crack. And though IVL has simplified the process, the patient had diffuse calcific lesions and calcium appeared circumferential. So only rota would not have been as effective as an IVL and sans the risk associated with rota ablation. So what is simpler than this can be labeled now as the most physician-friendly tool at this time. Rota, however, still finds a place in those places where the IVL balloon cannot be closed. Ladies and gentlemen, thank you so much. Now I will take questions.
I wanted to know why you are not doing imaging after doing that proper dilatation. Is that the balloon external look of an expansion is sufficient enough, or otherwise is either OCT or IVUS demonstration of the calcium crackling is an essential, especially the last case where you have so extensive calcium. It may not be much relevant in other moderate calciums.
Madam, that is a very good question. And I thought that you will ask me this question. The only reason why we are not doing imaging, and I'm fully convinced with the use of imaging, the only reason we are not doing imaging is because my center is not equipped with imaging. So we have rota ablation, we have IVL, we have FFR, but we don't have imaging at our center. So that is the only reason why we didn't do it. Otherwise, we would have definitely done it.
Probably no, now you'll get OCT combined FFR, not a simple OCT then.
Yes, we are planning on getting a new cath lab and that will be OCT equipped.
Okay.
So, ma'am,
that is ideal to know that it is a really effective bed preparation, not by simple injection of the coronary. Yeah.
Absolutely, absolutely. I agree.
So without imaging, at the look of the coronaries, how do you decide whether you are going for an IVL or not?
Madam, if you look at the amount of, okay. So whenever I see a coronary, if it is very tight, the IVL balloon is quite bulky. Now, if the size of the coronaries is less, you can say, not very large vessels, if they are smaller size vessels, if the lesion is very tight and there's huge amount of calcification, I go first for rota because the IVL balloon will not negotiate. But if you have large sized vessels, circumferential calcification, and not very tight coronaries, then you would do better with IVL because it's a bulky balloon. It can negotiate and it can work where, you know, the rota burr will not work. Rota works very good in very tight lesions where the IVL balloon will not cross. But if you think you can cross with an IVL balloon, the moment you have crossed with an IVL balloon, you don't need rota ablation because it will just about rupture any kind, intimal, medial calcification, everything it breaks. So if you're able to cross with the IVL, I choose IVL first. If I'm not able to cross with the IVL, even after pre-dilatation, you're not able to create enough space for the IVL balloon. With the IVL balloon, you cannot struggle. The moment you struggle with that balloon, it will get damaged. So if you have created enough place for it to go in smoothly, then use IVL. If not, straight away go ahead and use rota.
You have cases where you have shifted, you have tried IVL, failed and gone back to rota?
Where the IVL has failed and gone back to rota,
you have cases
yes.
where the balloon has not crossed and then the rota could easily do it?
So there was one case in which we used a combination therapy, and I used a combination therapy because initially we thought that we'd be able to cross with the IVL balloon. But unfortunately, when we tried to pre-dilate and make way for the IVL balloon to go to, it was not going in. So we had to switch back to rota, go ahead with rota, but the IVL balloon had already been opened. So post rota, I took the IVL balloon inside and then used that also. So it was a rota shock combination case. We published it also.
So, ma'am, in the case that you were showing, you use the first balloon and you gave. Was after the first dilation only that it ruptured, or it was after 2 or 3 dilations?
Dr. Shiba, you had asked this question, and I wanted to answer it for you. This is very interesting because what this has happened in 2 of my cases that the balloon has ruptured. Okay, what happens is the first dilatation when we were giving, we were around 5-6 pulses down, and suddenly there was a rupture. No, sorry. In the first case, what happened is we went up to full pulses, and then we inflated to 6. The moment from 4 to 6 we went, it ruptured.
In the first dilation itself?
In the first dilatation itself. Now, that is a very bad situation, especially for a private sector cath lab, because everything the patient has to pay for.
Yeah, definitely.
You understand what I'm saying?
Yes, I understand.
Suddenly you have to go out and tell them again that now you have to pay 3 lakh rupees more.
Yeah, yes,
so it becomes a very sorry situation for the, cardiologist.
Yeah. So when they gave
luckily for the new technology,
the second balloon, then how many times you had to go, ma'am?
Then we decided, so we had a talk there's always a company person around. So they called up the head office and they said that, no, please go up to 4. We'll give you the second balloon free of cost, but don't go beyond 4. So then for the second, we went up to 4, stopped. And now whenever I see a lot of calcium and I feel that I need to use this balloon more somewhere else in the coronaries, I don't go up to 6. We go to 4. See, the idea of going from 4 to 6 is that it causes a dilatation. There is no additional benefit. The ultrasound pulses are delivered at 4. So don't use this balloon for a dilatation. Use it only for the delivery of the pulses. So go to 4, deflate. No need to go up to 6 after that.
So now any adverse effects when the balloon bursted? Any change in the clinical scenario?
Luckily, in our case, nothing happened, madam. But yes, it could have happened. There could have been perforation, there could have been dissection. But because 4 atmospheres is a relatively lower pressure, so usually you don't face any problems. In both of my cases where the balloon ruptured, we did not have any adverse effects.
That's what the company actually advertised, that even if there is a rupture, there is no risk of any major adverse effects?
It's extremely rare, madam. Because, it is extremely rare of adverse effects in case of IVL balloon rupture because the pressure is relatively low. Since it's only at 4 atmospheres, so adverse effects are rare. But I have gone through case reports and they have reported one case in which a perforation occurs using an IVL balloon. So that can be there, but it is extremely rare for now.
So, ma'am, in Euro interventions, actually, just recently, there was a very interesting data where they talked about shock topics with the IVL. That because of that electromechanical coupling and the asynchronous spacing and induction
so with, use IVL. If you watch the monitor closely, you will see there are some ectopic beats, and these are called the shock topics. These are usually because of the the balloons which are formed inside the balloon when these ultrasonic therapy is given. So that sometimes goes and stimulates the ventricle, and there are shock topics reported, and you can actually see them on the monitor. They'll come 1 or 2 beats and then they'll disappear. They are usually known to be benign. They have not reported any major adverse events because of it. There have been no episodes of VT or VF. Incidental reports are there of atrial fibrillation having occurred after the use of IVL, but no cases of VT or VF have been reported. Shock topics are occasional ectopics which have been noted when using IVL.
They said about,
yes, and we have also observed
asynchronous cardiac pacing and your lesion was pretty long, ma'am, which you had dilated. So in Disrupt CAD 1 and 2, the maximum lesion length was 32 mm. Now this TCT, which is brought Disrupt CAD 3, the lesion, I think maximum is 48 mm, so 48.
They have gone up to 40 millimeters. 48. But like I said, I think the basic rule of intervention is whenever any new technology comes in, the more you apply, the more you try new things with it, the more the indication expands. So I think
another thing was
come across things like this when, and especially when the patient categorically denies a CABG. We used 2 stents in that LED case, the last case. So it ended up as a pretty long lesion. But then what other choice did the patient have?
Yeah, but then we can always use the same catheter can be used at 2 settings if we have not employed for more than 80 pulses. So you had 40. So if needed proximally.
In fact, frequently what I do is if I'm doing a double or a triple vessel case, then I use the pulses in the different vessels also. So usually in one vessel, if you, in 40 pulses, usually your job is done. So you still have 40 pulses left and you can use it in the other vessels also. The IVL balloon cannot be, ETO'd and reused again. So your 80 pulses, if you're able to use it in that case, well and good. Otherwise, it goes to waste. For now, it cannot be reused.
Interesting was also the role of IVL, which they've mentioned in eccentric calcium, like with Rota and other balloons that we have. They say that when we inflate, and if it's an eccentric calcium, that at the point of fibrocalcific junction, it's believed that dissections might occur, which is not usually the case with IVL because it gives us circumferential
dilatation,
dilatation and axial splitting of the calcium. So I think the ease of learning it for a newer person and performing this procedure makes it very catchy, but at the same time, cost in Indian setup is huge. So
I think especially for our younger operators and for our operators who don't have so much learning experience in rota ablation, for them IVL is it's a blessing because it is very easy to use. The second thing is that what they say about IVL is that it is soft on soft tissue and it is hard on calcium. So the soft tissue is not damaged by IVL, whereas the calcium is broken down by it. When you're doing rota, you end up damaging both the soft tissue and the hard tissue. So you have to be very careful and experienced when you're doing rota. But such is not the case when you need to do IVL. IVL can be used even by relatively new operators and very So I think it adds to our, armamentarium of dealing with calcified lesions. I always say that there is always a space for rota because whenever I take up a calcified lesion, I make sure that I have rota ablation IVL both in the lab. So luckily my center is blessed to have an IVL generator there all the time and a rota there all the time. So that makes it helpful for us. But I feel that whenever we attempt such lesions, both should be available. And of course, OPNNC and cutting balloons. with these four things, the use of guideliner, because frequently in calcified lesions, even after you've broken the calcium, getting the stent to that point is many times a difficult situation. So again, guideliner is very useful in these such situations. So it's a combination of all of this, but IVL has made the job much simpler.
And as Dr. Jyotsna and Dr. Lalita was saying that it is, not just for an intimal but medial. So even in-depth calcifications have been handled very well. I think Dr. Lalita was making a comment. Dr. Lalita,
Dr. Lalita, please, I would like to hear your expert comments.
Anyway.
Nothing. It's already covered regarding that long lesion. What I was worried was whether you could complete with that 80 pulses. It was quite a long lesion.
Yes.
You said you completed it with 40 pulses.
Yeah, the only one
Maybe that is the reason why they did not go for longer lesions in the initial trials with IVL, because you need more pulses and maybe you require more than a single balloon.
True, possible.
Yeah, one more point I wanted to say, it is the last case where the extensive calcification is there. Even there, rotablation is quite risky. Cocci phenomena can occur in these cases, and we have seen it. So extensive calcification, we think that it's better to take a rotablation there than IVL. But even rotablation, we have to be very, very careful with such an extensive calcification.
Very true, madam. Very true. So in that case, I thought that rotablation would actually be more risky because the calcification was extending all across the vessel. So that's why we attempted first with the IVL, and luckily we were able to do it with
the guide wire bias with the rotablation is also an issue, no? When we compare it as a technique with the IVL, the wire-induced bias in the rota.
Yes, and with the wire-induced bias, what I will say that if you notice the last case, my stent was not going in even after IVL. And why was that? Because there was a bend over there. Now, I tried to straighten out that bend with an OPNNC balloon, with a non-compliant balloon, 2 wires, everything, trying to straighten out the vessel. But the bend refused to, straighten out. Now, when you have to negotiate a bend, ultimately I had to take a guideliner. When you take a rota in, and when you are trying to cross the bend, many times through the bend and you have a perforation over there. So bends have to be dealt with very carefully when you're taking a rota in, because at the bend, usually you will have a complication. And then
yeah,
there's a problem.
Yes.
Yeah, I thank everyone. Actually, it is an extensive, excellent discussion of an IV. Really thankful to the Dr. Hannah, Dr. Sarita Rao, Dr. Shiba, Dr. Lalita, Dr. Mona Bhatia, and Dr. Meera Govindarajan, and such an extensive, clear ideas. And I'm thankful, really, Hannah, for the basic teaching. And next time we will hear the complications, how to tackle. Actually, she wants to present a annular perforation of the tabby. Then I said that first, please go with the basic ones. Then it will be the much more easy. Otherwise, we start with an annular perforations. Everyone will be scared, dread and complication. How it can be tackled. So the next time, I request Hannah to present about the complication management of it. And thank you all. And a special thanks to Dr. Rahul from the Torrent to giving this opportunity. Anyone, please? Anything?
Thank you very much. It was really
thank you very much
interesting.
for such a wonderful session.
Thank you.
So, ma'am, if you allow me, I officially conclude. First of all, thank you for this unique sessions which we've been doing with WINCARS. And I thank each one of you, especially Dr. Hannah, Dr. Sarita Rao, Dr. Shiva, Dr. Jyotsna, Dr. Nemani Lalita, Dr. Meera, and Dr. Mona Bhatia for being there with us. Our platform is always available with you, ma'am, for this particular kind of scientific sessions. And we are looking forward for many such WINCARS meet in the days to come. And I hope that your support with Torrent continues to be there in the times to come. Thank you. Good night and take care, ma'am. Thank you so much.
Thank you. Thank you very much.
Thank you. Thank you.
Good night, everybody.
Good night, ma'am. Take care.